Top Bed Talk.
Great. So it gives me great pleasure to introduce this afternoon's session, which is a hybrid. We're looking at some controversies in prehabilitation and then are going to present some work to you about a modified Delphi consensus project to try and affect standardization in prehab interventions, outcome reporting and trials. And it gives me great pleasure, first of all, to introduce Andrew Davies. Andrew is a upper GI surgeon at Guy's and St Thomas's Hospital in London and has recently chaired the perioperative quality improvement modified Delphi consensus regarding prehabilitation in esophagectomy surgery. And he's going to talk to us today about whether we should delay surgery for prehab. Thank you, Andrew.
Thank you very much, Denny, for the introduction. And as you say, the topic of my talk is, should we delay surgery for prehabilitation? Afraid I didn't get the dress code memo here, but I'm just going to stick to my guns as the stereotypical surgeon amongst anaesthetists and keep my tie on. And it's a real privilege to be invited to speak here today, and also a great privilege to share the stage with such an incredible group of speakers. But the subject that I've been given is not necessarily an easy one, and it's not an easy one to get through in 10 minutes, but I'm going to try and have a go anyway. I have no disclosures. There are a number of caveats to my talk, and the first is that prehabilitation is for all patients, not just the surgical cohort. And of course, this is something that was very clearly laid out by the Macmillan studies that were cited earlier on. And the second caveat is that benign patients are just as important as cancer patients. They have in some ways less time pressure and should be offered prehabilitation, provided that there's an evidence base for that intervention. And of course, that needs to take into consideration the complexity of the surgery, patient characteristics, and of course, resource limitations. But for the purposes of my talk, I'm going to focus on cancer surgery, principally due to time limits. So in terms of delaying surgery for prehabilitation, we've got a number of pertinent questions. The first of which is there a proven benefit for our intervention? The second might be considered as a dose-response relationship, so is 4 weeks of prehabilitation better than 2 weeks? And then what are the potential downsides? So for example, obviously delaying cancer treatment. And then if time is short, can we deliver the quality of the intervention that we all want to deliver? And there may also be some secondary considerations. Are there any precedents in delaying treatment? So, for example, we frequently delay surgery after neoadjuvant chemotherapy. And then what are the impacts of different treatment pathways? So, for example, primary surgery being a very different setting to neoadjuvant chemotherapy. The magnitude of the surgery, so an esophagectomy is a very different intervention compared to wide local excision of a breast tumour, for example. Which outcomes are we actually trying to improve? Is it complication rates, chemotherapy response? Is it survival? Is health-related quality of life enough? And in saying that, it's not that I'm trying to belittle the importance of health-related quality of life. Far from it. But if you're trying to balance health-related quality of life with a delaying of an intervention that could compromise survival, these are difficult balances to strike. And then one thing is to justify an intervention during treatment, such as chemotherapy or radiotherapy, but it's another to actively delay treatment in order to deliver your intervention. And I think one of the really important things that seems to have been a theme throughout the morning as well is, what do our patients think? Because it's definitely not always what we think. They definitely have anxiety around treatment delay, and we see that in cancer clinics all the time. The moment it gets to 1 or 2 weeks of delay of cancer treatment without staging investigations, there are definitely questions that we are fielding from our patient group. And then we have to just accept that there are quite a significant proportion who don't necessarily believe in or want to engage with prehabilitation. And so these are just two survival curves from the PREEM study that we performed in Guy's and St Thomas's, and showing that the red and the blue curves are the intervention and control groups of patients having an esophagectomy who were entered into an exercise or not, or controlled trial. And then the green curve are patients who declined participation in the trial or withdrew very early before meeting the trial criteria. And that's showing significantly worse overall and disease-free survival in the non-participants. And this is just highlighting really that group of patients who are currently inaccessible to prehabilitation programs that it's really important that we don't forget. So is there a proven benefit for prehabilitation? All of the numbers coming up in red are in esophagogastric surgery, statistically significant study results showing a benefit in, as you can see, a wide range of outcome measures. And although the trials are all relatively small, often single center, when you take them all together, there does seem to be a very good overall body of evidence in favor of the intervention. But importantly, pretty much all of these patients are enrolled in a neoadjuvant chemotherapy followed by surgery pathway, which allows them to have 4 or 5 months in the lead up to surgery. And so then the question becomes, how long is long enough to deliver the intervention? And I'm sure we've seen this graph on a number of slides previously this morning. If we have X number of weeks in the lead up to an intervention, clearly the shorter the intervention, the closer that those two curves come together, and potentially the more marginal the benefit. So if we look at a primary surgery group, we're potentially dealing with someone who's got quite tight timeframes, maybe even 4 weeks between diagnosis and surgery, potentially even less than that. And so if we pick them up halfway through their staging pathway, we may only be allowing 2 weeks for prehabilitation intervention. So one of our options then would be to delay surgery. That clearly has potentially some compromises. Or the other option would be to actually improve our pathways and to pick those patients up sooner and allow a longer intervention period. And potentially we could do both. So in terms of looking at this question, I asked a number of professionals from all of the pillars of prehabilitation what they felt in terms of minimum timeframes. And as a general rule of thumb, most people said anything is better than nothing. But there is a feeling that 2 weeks may be a minimum for an exercise intervention, but of course, the longer the better. In dietetics, again, another feeling that 2 weeks would be a minimum, and in patients who've got severe nutritional compromise, such as esophagogastric patients, ideally, if you're going to reverse any of that compromise, you would need longer. And then in psychology, I was somewhat surprised by the response that a feeling that 2 weeks might be too short and potentially even harmful. Insofar as if you recruit a patient into prehabilitation for 2 weeks and then ditch them at the end of that period of time and don't see it through the course of treatment, you could potentially cause harm, and that this should be considered as a more layered and longer term intervention. So in terms of the downsides to delaying treatments, clearly tumour progression would be one concern, patient anxiety another. And if we look at potentially an intervention like prehabilitation with rates of non-compliance, and we'll then look at an analogy in other aspects of their cancer treatment. If you give a patient chemotherapy, and if they don't respond to chemotherapy, their survival is actually worse than a patient who didn't have chemotherapy at all. And so that is just a stark reminder that if we put people into prehabilitation and we fail in terms of compliance, that we could also be doing them harm. But after neoadjuvant chemotherapy, we often delay surgery for 6 or 8 weeks to allow recovery, but with the important caveat that they've had some anti-cancer treatment, and that will carry on delivering some sort of ongoing effect. We're balancing the risk and benefits of an immune recovery versus the possibility of progression, but we do see about 5 to 10% of patients progress on or after chemotherapy in that 4 or 5 month window. This is a very elegant study looking at solid tumours, looking at the tumour volume doubling time in months. And as you can see from the curves on average, most of these tumours have a 3 to 4 month doubling time in terms of their size. And some tumours have resectability issues, so the pancreas, the esophagus, potentially brain and others, and may be more affected than others by a delay in treatment. You may read between the lines that anything more than a 6-week delay untreated would cause some concern from a cancer perspective, and that might even be shorter than that in a tumour such as pancreatic adenocarcinoma. And you'd only really then do that if you honestly believe that the benefits of prehabilitation strongly outweighed the risks of progression. And so again, these are the worst surviving tumours in terms of 1 year survival, so highlighting a group of cancers in whom we'd be the most worried about delaying treatment. But unfortunately, they're also the ones who tend to have the most morbid surgery, and therefore they would be a group of operations in whom ideally you would like to try and deliver a prehabilitation intervention. This is only a draft. This is a summary of infographic that was developed from the joint ORGIS and POCI process that we've been through recently with a number of people in the room. And really, this is just highlighting the standard of a prehabilitation intervention that we all aspire to. So all patients from diagnosis with regular contact, wanting aerobic and resistance training with a personalised programme in a suitable setting, and that would now be considered standard of care. But also an intervention that is prescribed, clearly defined, with validated baseline assessments, aiming to improve fitness and strength, and a response monitored. And so if we're trying to deliver an intervention within a short time period, and if we're not meeting most of those aims or goals, then we have to question what exactly we're doing and whether that's effective. So a few of secondary considerations. So if we think about primary surgery and we're trying to maximize that time window of, let's say, roughly 4 weeks, in a neoadjuvant setting, we've got lots more time. We may also have some other benefits that Malcolm's going to talk about tomorrow in terms of enhanced chemotherapy response. Is the greatest benefit in high-risk surgeries, and that's quite possibly true. Prehabilitation may reduce the number of complications, which may then affect all of the outcomes there on the right, but we also need to remember that the mechanisms by which prehabilitation may improve those outcomes are quite complex, and not all of those will be delivered through the model of fewer complications. So, in answer to the question, should we delay surgery? I think it's probably fair to say more robust data would help. We had a less heterogeneous intervention with agreed standards of care, and definitely a better understanding of the time period required to gain our benefit and which of those benefits are gaining. And then the practicalities of initiating a genuine prehabilitation program in time to make a difference. So in reality, what does that mean? I think it means an individualized decision. Seems to be a theme throughout the meeting, but that's based on the risk-benefit, which may be determined by a number of factors. So the type of tumour with its natural history and biology. What's the magnitude of the operation? Is it a very high-risk procedure or low? What's the treatment pathway, primary surgery or a neoadjuvant strategy? And then the individual patient. Are they high risk, low risk? And then what outcomes are you trying to improve? Because if you are trying to minimize complications in a high-risk patient with a view to delivering curative treatment options, that may well then justify a delay. If someone managed to prove either a survival or a chemotherapy response benefit, it would be worth doing it for all patients. But if you're delaying a relatively low-risk operation for a health-related quality of life benefit, then there would be much more of a discussion regarding the pros and the cons of that. And then finally, I think most importantly, taking into account patient views and perspectives continues to be extremely important. So thank you very much for your time, and very happy to field any questions.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.